Next is about the colonic disorders. Among the disorders of the colon, the most common and quite significant clinically would be colitis. Colitis means inflammation of the colon, and it could be of different varieties. They could be like either infectious, that's bacterial, parasitic, and so on. Then allergic colitis, pseudomembranous colitis, ischemic colitis, colitis secondary to immune deficiency disorders, Crohn's disease, ulcerative disease, indeterminate colitis, or necrotizing enterocolitis. Of course, these are just a bit overlapping nomenclatures. Some of them are almost similar issues. So we will be discussing somewhat in detail about the infectious colitis because that's quite important clinically, and then the Crohn's and ulcerative colitis somewhat in detail. Rest of the things we just pass on with some simple issue references like. Among the infective colitis, from Indian context, from our practical clinical issue, amoebic colitis is the most common. In our coastal area, amoebic colitis is a quite common condition, and hence we discuss that as the first condition. Amoeba again is a single cell organism which is presented or which is present as endemic areas, and the life cycle of the amoeba is it's presented as a mature cyst initially, and the mature cysts, when they are just taken into the gastrointestinal tract, they break down and they produce the trophozoites, and the trophozoites will be present in the intestines as such, and they release the live amoeba, and the live amoeba again gets into mature cysts, and then it may be transmitted from one to the other through the fecal-oral route. So life cycle of amoeba requires the host of the human body, and of course it may be transmitted through the fecal-oral route. And when the source of water, most of the times is a source of the water, which is the main medium to which the amoeba is transferred. So it's a fecal-oral route transmission as such, and usually occurs as an epidemic like. Now, Entamoeba histolytica, the most common species of the Entamoeba which is present in our area. Of course, there are many other species of the Entamoeba which are not really significant from our point of view in our area. In other countries, in some areas, the other species of the Entamoeba are more common. Here in our area, Entamoeba histolytica is the most common condition, and it can present with the intestinal symptoms. When it gets into the intestines, in the intestinal phase, the clinical presentations could be of any varieties, and they could be a large number of people may remain asymptomatic carriers, particularly in our coastal area, in Udupi, Mangalore, and so on. If you examine the stools of the people, majority of the people would have the amoeba in their stools, but they are asymptomatic. It's a quite large number as such seen, and the asymptomatic infection could be presented in a large number of people. Symptomatic invasive, non-invasive infection, mild symptoms may occur, or acute proctocolitis, which we call as dysentery, the more common and clinically important conditions. Clinically important conditions are mainly proctocolitis or symptomatic non-invasive infections where mild symptoms could occur. Then fulminant colitis with perforation, severe acute colitis with perforation, incidence is lesser, but when it occurs, it is a significant clinical. Incidence is quite less common as such. Toxic megacolon also is another of the rare complication of the intestinal entamoeba histolytica, amoebiasis as. Then chronic non-dysenteric colitis. Many of the patients may have colitis which resembles other irritable bowel syndrome like conditions due to the amoebiasis. This also is somewhat common. Amoeboma are again not so very common in our area. In India, as such, amoeboma are less common, but in some other countries, amoeboma are more common. The Entamoeba histolytica, amoeboma is simply a mass formed in the mesentery of the intestines due to the amoeba, and the lymph nodes and the omentum, they forms a mass and palpated as a mass like. Rather, the other way which we see more frequently would be amoebic typhlitis, inflammation of the cecum, which may be often felt as the mass as such. So amoebic typhlitis may be seen, and perianal ulcerations and fistulae. These also are the other relatively rare complications of the amoebic colitis which we see. Then extraintestinal conditions of amoeba histolytica, liver abscess, which we have already discussed in the liver pathologies. Then the other conditions are pleuropulmonary disorders, where there could be involvement of the pleura and lungs, and then there could be infectious lesions in the lungs. Of course, with amoeba histolytica, this is less common, but occasionally we may see that. Peritonitis either as a complication of the liver abscess, or it also can occur independently occasionally, or due to the perforation of the colitis, permanent colitis conditions also can result in peritonitis. Pericarditis is still rare with the entamoeba histolytica, but rarely it may occur. Brain abscess or genitourinary diseases also can occur as a complication of the entamoeba histolytica, but they are less common. So most common and quite important is the intestinal manifestations, either mild or severe. That's the most common, and our focus of discussion would be over the intestinal manifestation only. Now, amoebic infections can lead to significant morbidity, particularly if the patients are either it can amoebiasis is quite severe in children, or especially neonates, pregnant and postpartum women, those who are using corticosteroids, those with malignancies, or patients who are malnourished. In these conditions, amoebiasis can be a fatal condition. Otherwise, amoebiasis is relatively chronic, not so or hazardous condition, and it's considered to be one of the serious issue of protozoan disorders, only second to malaria. Malaria is the number one disease. Particularly, all these are true in our tropical area. This data, this information may not be so true in Western countries where amoebiasis is less common. In the Western country, amoebiasis is less common, and hence in the Western medical literature you will find lesser information about the amoebiasis, intestinal amoebiasis, whereas in India it is a more common, India and other countries like. Asymptomatic intestinal amoebiasis occurs in about 90% of the infected individuals. In the sense, once the patient has an amoebiasis, he remains asymptomatic intestinal carrier for a long duration or many times for the whole life. And that's why if we examine the stools of the people here, if you do a survey of the stools, a large number of people would have the amoeba cysts present in the stools, but they may not have any symptoms. Case fatality rates associated with amoebic colitis is just around 1.9% to 9.1%, depending upon the physical condition of the patient. So fatal complications are less common, and this 1.9 to 9.1% range is depending upon the status of the patients. Patients who are from the poor community, malnourished people, the fatality rate is more, or the patients who have other systemic illness, the fatality rate is more. Amoebic colitis resulting in necrotizing colitis may rupture in only 0.5% of cases. These data are from all over India, pan-India data. These are from the data from central this registry, central government registry, and this data shows all over India. But the distribution of these diseases are not uniform. I will come to that part later. Recent treatment protocols have reduced the mortality rate of liver abscess to 1 to 7%. See, earlier liver abscess was having more fatal results, but with the current line of treatment, it's lesser. Pleuropulmonary amoebiasis has a 15 to 20% mortality rate, though the incidence is lesser. Once there is involvement of the lungs or pleura, the fatality rate increases. And amoebic pericarditis has a fatality rate of 40%. Cerebral amoebiasis is very high mortality of 90%. But luckily, these complications are rare. So, the importance of the amoebiasis has to be considered considering these fatality issues. Now, global incidence of the amoebiasis, it's the distribution seen, it's again based upon the global data. India is one country where intestinal amoebiasis is more common. Hepatic and the next, and pulmonary amoebiasis are the common conditions. Cerebral amoebiasis is extremely rare in Indian country, but incidence of the intestinal amoebiasis is quite high as such. compared to other countries. Whereas within India, prevalence of MBBS it is again is based upon the data of the central government as such. The prevalence of MBBS ranges from 3 to 23% in asymptomatic population. Patients who do not have any symptom. If you screen the stool examination, based upon the data available, about 3 to 23% of the persons population have amoeba carrier. This is the data averaged for whole of India, but it can be more in certain areas, particularly in certain areas like our coastal area. The incidence is more, or even in the highest this prevalence is seen in Tamil Nadu, Andaman Nicobar, and Northeast India, as per the central government data. Of course, coastal area is not included in or is not added in the list of that high prevalence conditions, but it's also a high prevalent zone as such. And it's 0.64 to 11% of the symptomatic patients and 1 to 17.5% of HIV infected patients. HIV infected patients are having this condition. Worldwide, approximately 50 million cases of invasive endomyxillin disease occur each year, resulting in almost about 1 lakh deaths throughout the world. So, it's an important condition from our point of view. Clinical presentation of intestinal amoebiasis. We will limit only to the intestinal amoebiasis. The most common and the very characteristic clinical symptom is abdominal pain, which is a cramping type of the pain. Usually, the pain precedes defecation. Before the stools, the patient may have a cramping pain in abdomen, and then the patient may pass the stools. Usually, the stools are watery or bloody containing, but the number of frequency is not usually more than 6 to 8, and it contains more stools and mucus than the watery or blood. Now this makes the difference. This helps you to differentiate between a bacterial colitis and amoebic colitis. In the bacterial colitis like conditions, frequency would be quite high, usually more than 10, 15 or so on maybe, and when a bacterial colitis, the patient would have more watery stools, and at times there will be stool content would be very less. It could be only thin as such. There could be more of blood than the mucus. Whereas in case of amoebic colitis, there will be more of mucus, lesser blood, frequency is lesser, and the clinical toxic symptoms are relatively milder. And that makes the difference in majority of the patients of amoebic colitis and bacterial colitis. Of course, in a fulminant amoebiasis, the symptoms may mimic that of bacterial colitis and their number is lesser, there you may miss the diagnosis. Anorexia, weight loss is the other symptom. Fever seen is only in lesser number of patients, 10 to 20% in amoebiasis, whereas in case of bacterial colitis, fever is seen in almost every patient. Almost more than 90% of patients would have the fever as such. A large number of patients of amoebiasis may have clinical symptoms which resemble that of the appendicitis, and it's one of the important differential diagnosis of the appendicitis. And particularly in our area, this is quite significant. When amoebiasis occurs and it involves the cecum, the whole cecum becomes swollen and the cecal tissue becomes fragile, something like a butter. And surgical intervention in such condition often can result in more complications, and hence in every diagnosis of appendicitis, you have to be careful to rule out the possibility of amoebic typhlitis, because amoebic typhlitis can produce a more fragile cecum, and handling that surgically can result in more complications. Rectal bleeding without diarrhea also can occur in a few of the patients, particularly more common in children. Symptoms of proctitis where the patient may have pain either before defecation or after defecation. And the difference between a proctitis and fissure is in the fissure, the pain always starts after the defecation and then it stops suddenly. It lasts for a few hours and then suddenly stops. Whereas in case of proctitis, the pain starts before the defecation and continues even after the defecation and may just get reduced gradually, slowly after a long time. Then, so that's how you have to differentiate between a proctitis and the fissure. And among the proctitis patients whom we see in the clinical practice here, majority of them have the amoebiasis as a cause. Lower abdominal pain is other. Dehydration comparatively lesser and but may be seen in children, malnourished people or HIV positive patients. Dehydration due to amoebiasis could be seen in other conditions. A massive dehydration or significant dehydration may not be so common. Fulminant colitis, severe acute colitis with the whole colon becomes swollen or even perforation can occur and the patient may be very toxic. It's only in 0.5% of the patients and there could be always a predisposing factors of fulminant colitis, maybe poor nutrition, pregnancy, corticosteroids uses, patients who are on corticosteroid for some other reasons, very young age of less than 2 years, and in such conditions, perforation may be more common. Patient may present with all the clinical symptoms of intestinal perforation in such conditions. The major complications of amoebic colitis are a fulminant or necrotizing colitis. A amoebiasis initially may present as mild and then it may suddenly flare up and result in a fulminant colitis. Or toxic megacolon. Toxic megacolon we have already discussed in the megacolon conditions previously, where the whole intestine, particularly large intestine, becomes dilated and the toxic absorption could occur. Amoeboma, that's a mass formation in the abdomen, is the other complication, which often produces confusion with an abscess, or an amoeboma may present exactly like an abscess back condition. Rectovaginal fistulae of different sorts, because amoebiasis, the colon involved in the amoebia, the amoebic ulcers may just leak out and that leaked content may find a pathway to the exterior, either through the vagina or in the perirectal area, and can produce the fistulae. Fistulae which have a high connection into the intestines at any level may be the other complications like perforation of the bowel is, as I said, it's a fulminant colitis like conditions, comparatively rare as such. A massive bleeding also can be the complication. A amoebiasis treated once may result in a stricture. The ulcers may heal with fibrosis, and that fibrosis can result in stricture formation, resulting in obstructive symptoms in due course of time. Patients with amoebiasis also are prone to develop intussusception. Intussusception we have already discussed in the intestinal conditions. Because of the edema at the area, the momentum of the intestines at that level where there is inflammation may not be the normal, and hence there is a possibility that the patient may develop intussusception. Peritonitis and empyema, pus in the abdominal cavity, also can occur as a result of peritonitis. It could be the complications of these. Investigations to confirm the diagnosis of amoebiasis are one, commonly the peripheral blood leukocyte count. The leukocyte count may be slightly raised as such without eosinophilia, which is seen in about 80% of the patients. Alkaline phosphatase level is raised in about 80% of the patients. Mild increase in the transaminase levels, though the patient may not have a hepatic involvement, because the amoebae are destroyed in the liver, there will be a load on the liver, and hence the transaminase level may be slightly raised, not very significant. Bilirubin level also may be moderately raised, not very significant, and not seen in all patients. And albumin level may be reduced. Anemia could be the other. ESR may be raised. So, from the current our point of view, the most confirmatory test would be the stool examination. Examination of the stools is the most reliable method of making the diagnosis of amoebiasis. But there again, you have an issue, like because you have a patient with a large number of people with the asymptomatic amoebiasis, whether the symptoms presented are due to the amoebiasis or not is the question. But if the stools show live amoebae, not the cystic conditions, then that confirms as such. And the standard protocol for the stool examination is a single stool sample is having a sensitivity of only 33 to 50%. There is a possibility of negative findings, and hence the standard is examination of 3 stool samples over not more than 10 days, within a gap of 10 days. 3 stool samples, if there is a positivity, then the percentage would be that accuracy, sensitivity will be around 95%, and that's the most reliable method of making the diagnosis. Of late, very recently, the other immunological tests like enzyme-linked assays, ELISA tests, or polymerase chain reactions, or immunofluorescent assay tests are now becoming popular to confirm the diagnosis of amoebiasis. But these tests are quite costly and may not be still practicable in the routine conditions. But in future, or rather in many high centers, this has become a routine thing, like to make the diagnosis, which we may not follow. See, in our routine clinical practice, we may not still in a position to do these tests. ELISA PCR tests are not done for the diagnosis of amoebiasis. Most of the times, the diagnosis of amoebiasis is based upon the clinical factors as such. The other investigations which could be somewhat accurate would be the colonoscopy. Though the colonoscopy is not a regular investigation, not suggested, recommended as a standard condition, but in chronic amoebiasis, it helps in differentiating that. The characteristic appearance on the colonoscopy would be discrete ulcers which have a raised edge and a narrow opening, and the ulcers are deep and they reach up to the muscular layer, and these ulcers are called as flask-shaped ulcers. Number of ulcers are more towards the proximal area of the colon, towards the cecum, the right side of the colon, the number of ulcers are more, and the number of ulcers on the left side of the colon would be lesser. So that would be the typical feature of amoebic colitis, and this appearance in the colonoscopy helps to differentiate from other conditions like bacterial colitis or ulcerative colitis. In the bacterial colitis, there will be a generalized inflammation of the mucosa, and ulcers would be very superficial erosions, unlike the amoebic colitis, which are deeper. And in case of ulcerative colitis, ulcers would be discrete ulcers which tend to coalesce, multiple ulcers which tend to merge together with a small bridge of normal tissue. So when we discuss is bacterial ulcerative colitis and the bacterial colitis, I will show you the images of colonoscopy, which helps you to differentiate. But the other important characters of the amoebic colitis are the flask-shaped ulcers. Stool examination showing the live amoeba is the most reliable method of investigation as such. CT scan also can help in particularly in the patients of amoeboma or typhlitis, involvement of the cecum and the swollen mucosa, the colonic wall becoming thickened and the cecal wall becoming thickened can be easily differentiated from the CT scan. So CT scan occasionally may be useful, but in routine conditions it may not be necessary. The earlier methods of investigations were barium enema, but these days, because of the popularity of the colonoscopy and CT, this has become less popular. But still, because we are discussing academically, I am just referring to this also. A barium enema, if it is done properly, it can demonstrate the typical flask-shaped ulcers. The flask-shaped ulcers, projections over the area, is a very characteristic. So, are the cecum being swollen now? These flask-shaped ulcers, very typical seen, would be the signs of the barium enema X-ray. Earlier days, when CT and colonoscopy was not popular, that's in the 80s, the barium stomach duodenum or barium enema X-ray was the most reliable method of investigation at that time. But now, this is not popular as such. Now, once you have made the diagnosis, the treatment would be primarily anti-amoebic drugs. Among the anti-amoebic drugs which are used, the most significant are metronidazole, tinidazole, paramomycin, and diloxamide furoate. Of course, the most common and comparatively safer would be the metronidazole. The standard dosage schedule in a acute amoebic colitis would be 750 mg per day, 3 times a day for 7 to 10 days, or in children 35 to 50 mg per kilogram body weight in 3 divided doses for 7 to 10 days. And the major adverse effects of the metronidazole given orally would be it's anorexia, nausea, vomiting, diarrhea, abdominal discomfort, unpleasant metallic taste, intolerance to alcohol. This is important. Patients who consume alcohol, if they take metronidazole, they will have very odd feeling like burning sensation and so on. Rarely there could be neurotoxicity, maybe seizures also rarely occur. Peripheral neuropathy, confusion, irritability can be the complications of metronidazole rarely, but more frequent would be the metallic taste in the mouth. That's the most common clinical symptom. But metronidazole has made a revolutionary change in the outcome of the amoebic colitis. The other drugs which could be used are tinidazole. Tinidazole is only there is not much of an advantage over the metronidazole, but certain patients who may have either resistance to metronidazole or may have some more severe adverse effects and cannot tolerate metronidazole, they may tolerate tinidazole somewhat better, and the dose is 800 mg 3 times a day for 5 days. The duration is shorter, or in children 60 mg as such. Then the other way to eradication, the other part is peramycin or dilaxinate. The peramycin or dilaxinate, they are not absorbed from the gastrointestinal tract, and hence the concentration of the drug in the intestines will be more, and hence they are considered to be more effective in eradication of the amoeba. But they may not be effective in the amoeba which have already produced an ulcer and have gone into the body, have gone into the circulation. So the usual standard protocol is give metronidazole, and then along with that give any of these luminal agents. These are called as luminal agent because they are acting on the amoeba present in the intestines, and because they are not absorbed, and this combination is supposed to produce an eradication. But what I have observed is in our routine clinical conditions, because the people have become a very significant number of people are carriers, this eradication program usually fails. Rather, most reliable treatment there would be Agnitundi Anandabhairu Mustakarista for 1 month, and the patients would be absolutely asymptomatic with that, and compared to metronidazole, this drug would be better. Only in this protocol would be better, and the only conditions where you may need metronidazole would be when there is an acute condition or when there are significant bleeding like conditions, then metronidazole may be better, otherwise not. And the general treatment protocol, the other way, which is as a standard guideline for the other phases of amoebiasis, where this is a protocol which is suggested by the CDC, Central Drug Condition. But in our condition, asymptomatic patients, of course, that treatment is whether it has to be continued or not is a controversial issue. But from the standard medical point of view, asymptomatic patients also need to be treated, and there the drug of choice would be peramycin, the luminal drug acid. In the intestinal, as we have discussed, metronidazole or tinidazole. Patients who have developed liver abscess or severe intestinal disease, the dosage is increased and the duration of the treatment also is increased. That's the standard protocol of eradication of the amoebiasis, which is also a part of the National Health Program. But asymptomatic patient and eradication almost becomes irrelevant. Anyway, from the academic point of view, we have referred to that. So that's about the amoebic colitis in brief. The next is about the bacterial organisms or bacterial colitis. The bacterial colitis is produced due to a large number of bacterial organisms. I will come to that. But incidence is quite significant. About 11.37 million episodes of acute gastroenteritis in children below 5 years annually occur in India. So from the Indian point of view, acute gastroenteritis is a significant issue, and it's requiring about 3.27 million outpatient visits and 872,000 inpatient admissions, resulting in total direct costs of 10.37 billion Indian rupees to the Indian nation. So that's about the whole gastroenteritis, which is produced due to either virus or the bacteria. So from Indian condition point of view, bacterial gastroenteritis is very significant. And the bacterial gastroenteritis episode, and I would use, it's a gastroenteritis is the term used because it tends to involve both colon and the small intestines as well as the stomach occasionally. And often it's also named as food poisoning. So it's a group of disorders which present with acute diarrhea-like conditions. This also tends to have a seasonal factors. Incidence would be seasonal. In India, the more common varieties of the gastroenteritis would be either rotavirus induced viral gastroenteritis or bacterial gastroenteritis. The bacterial gastroenteritis is more common in summer, March to July, and then at the end of winter. Whereas viral gastroenteritis, it will be more common at the winter season. So there is a typical pattern of the incidence of the disease of viral and the bacterial gastroenteritis in our area. This data is relevant from Indian point of view. Then as far as the organisms are concerned and their incubation period, large number of bacterial organisms, we will be discussing bacterial gastroenteritis in the beginning. That viral gastroenteritis will reserve for the next part as such. It's a brief thing, right? Now, among the bacterial organisms which produce the infections, the common varieties of the bacterial organisms which are known to be there are Aeromonas, and Aeromonas usually produces the symptoms within a short duration, where incubation period is almost negligible. The whole duration of the disease lasts for about 2 weeks, not more than 2 weeks usually, and it's a self-limiting disorder. It reduces by itself if there is no other complication. And comparatively, there will be no pain, fever and vomiting may be or may not be present. So it's a sort of simple diarrhea-like conditions which we see as such produced due to Aeromonas. And from the clinical point of view, this kind of symptoms are quite common also, more common in the summer season. Bacillus species, the incubation period is 1 to 16 hours, and the patient would essentially have fever and abdominal pain. Vomiting and abdominal pain would be the major symptom. Duration of the symptom will be usually for 1 or 2 days. Patient would have more vomiting as well as the abdominal pain. That's usually Bacillus species. And Campylobacter, comparatively, they are less common in our condition, in our area, is less common, where the incubation period is around 2 to 4 days, and the duration is about a week, and vomiting is less common. Patient would have fever and abdominal pain. And Corynebacterium difficile is where there could be a variable. It's unpredictable. Vomiting is not common. Fever and the abdominal pain is less common, and this also is not common in our area. Or Corynebacterium perfringens is also not so common in our area as such. Salmonella is a more common varieties. Here in our condition, Salmonella species are more common. Either Salmonella typhi or other non-typhi species of the Salmonella also can occur. And particularly they are more common in this season. This season, rainy season, now you have, and particularly here this month as such, July and August, large number of patients are seen. Even now we have some 2 or 3 patients in the ward admitted. So the incubation period is 0 to 3 days, and the duration usually lasts for 7 days. In other species, typhi, Salmonella typhi, it can continue for 3 weeks. Vomiting is common. Fever is more significant and usually high fever. Abdominal pain also is common. Shigella species, the other variety, comparatively less common in our area. It's more common. Shigella is more common also, and particularly it occurs in the summer when the more due to the usually Shigella issues we tend to have in March and April when there is very hot season. This tends to occur, and fever is very high. Abdominal pain is there, and it may last for 7 days. The Staphylococcus aureus also is less common here. Vibrio species. Among the Vibrio species, Vibrio cholera is one of the serious issue which can present with very serious complications. But Vibrio cholera now, because of the immunization, incidence has become almost less common. But if it all occurs, it produces a significant epidemic. Then Enterocolitica is not so common as such. Food substances and the bacteria relationship also is another issue. And that's why it's also named as food poisoning. The other name given to the gastroenteritis is the food poisoning. And the food substances associated with specific organisms are dairy products like milk and milk products. Campylobacter, Salmonella, Listeria, Staphylococcus are involved. Eggs is mainly Salmonella species. Other meats of different animals, either perfringens, Salmonella, Aromonas, Campylobacter, or Staphylococcus species may be there. Beef which is ground, mainly under hemorrhagic E. coli. E. coli mainly in beef as such. Poultry, chicken and so on, more common is Campylobacter. Pork is a Campylobacter perfringens or Yersinia enterocolitis. Seafoods, Aromonas, because most of our area patients, they tend to develop the complication of the seafood complication. Aromonas is the other common condition which we see, where the symptoms are relatively milder. And the other species, Vibrio and Astrovirus species. Oysters, they are usually Leishmaniasis and Vibrio species. The vegetables, Aromonas, again, Aromonas is more common cause than in the vegetables. Contaminated vegetables are perfringens like sprouts, enterohemorrhagic coli, and fried rice, Bacillus species, custards and mayonnaise, Staphylococcus species. These are certain of those common conditions as such. When the patient presents with the symptoms as such, based upon the symptoms, we can make out whether it is a small bowel or the large bowel involvement. Usually, small bowel involvement produces more dehydration and severe complications. Large bowel involvement relatively milder. And from the clinical point of view, this differentiation is quite significant or important. If the patient has a small bowel involvement, irrespective of the organism, the stool should be very watery in small bowel, whereas in the large bowel involvement, there will be mucus and blood. In general, in all cases of bacterial colitis, the total frequency per day can be more than 8 or 10, like the frequency will be more. And the volume, in case of small bowel pathology, the total volume of these stools evacuated would be very large. And at the end, every time it's watery as such. Whereas in large bowel conditions, comparatively smaller. Frequency is very high in small bowel pathologies, whereas large bowel pathologies, the frequency may be 10 to 15, but not very high. Whereas in small bowel pathologies, it could be every few minutes, like the patient may feel like going for defecation. And blood would be presented in these stools, but when there is a small bowel pathology, you may not be able to see the gross blood. Gross blood would not be seen, but if you do the test for occult blood, it may be positive. Whereas in the large bowel pathology, gross blood can be seen. And in the small bowel pathology, usually pH is acidic, lesser, more acidic, less than 5.5. In large bowel pathology, it's more towards, it's still acidic, but on the higher level of towards the alkaline tendency. Then there could be the reducing substances like glucose present in the small bowel pathology, whereas in large bowel pathology, it's negative. If you do this biochemical test, it may be seen. White blood cells, WBC count would be lesser in case of small bowel pathology. It may be 5 or less than that, 5 in high power field, whereas in large bowel pathology, they will be high, more than 10 power high power field. Usual organisms with the toxins like Bacillus species and toxic E. coli or rotavirus, these involve the small intestines more frequently. E. coli, Shigella, and the Corynebacterium difficile or entamoeba, that amoebiasis species, they involve the large bowel. That's how the clinically, without going for this culture and other tests, you can make out to a great extent about the type of the organism. The most common clinical symptoms in general, irrespective of that, would be diarrhea, fever, abdominal pain, and tenesmus as such. The patient's other symptoms which could occur due to the bacterial colitis, comparatively less common, are perianal diseases, like the patient may have hysterectal abscess or the perianal abscess, or even fissures, tags, fistulae, and abscesses. That's the clinical symptoms which could occur. Any of the patient of diarrhea, also may have a involvement of the joints, arthralgias and arthritis, which we call as a reactive arthritis. One of the reasons for the reactive arthritis is a gastrointestinal tract pathology. Dehydration is the most serious and most common cause of the fatality, and the most important aspect of the management of the bacterial colitis. Patients having that bacterial dysentery or food poisoning, which we call as gastroenteritis like conditions, the most important part of the management is to manage the dehydration and prevent the dehydration. The other issues of significant would be toxemia, toxic megacolon and perforation. These are not so common, but they need to be effectively prevented, and once you prevent that, the treatment would be possible. Investigations which are suggested are mainly white blood cell, hemoglobin, platelet count, prothrombin time, and thromboplastin time. Electrolyte levels, quite significant is electrolyte level. And the intravascular coagulation profile also has to be done in such cases, and C-reactive protein. These are the investigations which are generally advised. The most important are the total leukocyte count and electrolyte levels, which are quite critical. Rarely you may need an X-ray or a radiological investigations in case of acute colitis, but if at all it is done, in a radiological features will be in acute colitis, the whole colon would be swollen and the peristaltic waves would be seen as such. The swollen or distension of all the intestinal loops would be the next radiological sign. Colonoscopy, if you do that, again, it's not generally indicated. It's not a general advice in case of the acute bacillary colitis. Rather, in the bacillary colitis, the colonoscopy has to be avoided because the tissue is fragile and there is a chance of perforation. But suppose due to some other reason, if you do the colonoscopy, the findings of the colonoscopy in case of a bacterial colitis would be a continuous source of irritation, the inflammation, where there will be mucosa will be denuded, either in forms of lines or it could be forms of the patch-like. So that erosion of the mucosa is a characteristic feature, and the ulcers are not deep, very superficial ulcerations which may even bleed as such. Then the most important part of the management is the oral rehydration therapy, and that idea of oral rehydration therapy has revolutionized the outcome of the management of this diarrhea, and the total fatality rate is reduced, and actually it was that oral rehydration therapy concept was rather established and publicized by Indian doctor Dilip Mahabalis, and in memory of him there is a World ORS Day on July 29th. Last week we had that World ORS Day, and it's to make the people aware of that ORS requirement. And the ORS, there is again two forms of ORS, standard and low osmolar. Low osmolar is usually given in the patients who have lesser dehydration, moderate dehydration. More patients who have severe dehydration is the standard, and the contents are in oral rehydration is having sodium chloride and trisodium citrate and potassium chloride and glucose, and the ratio in the general is 3.5 grams per liter of sodium chloride, whereas in low osmolar it is 2.6, and low osmolar is preferred in the patients who have renal pathologies also. Then the added live lactobacillus. Now patients who have diarrhea and the involvement of the colon with the bacteria, the symptoms can be effectively reduced, and particularly the diarrhea symptom can be reduced by adding either live or heat-killed lactobacillus. So many of the brands of oral rehydration products, which are ORS products, which are available in the market, may have already a bound lactobacillus, either live or killed. Most commonly heat-killed lactobacillus LB would be presented along with that, and that produces better relief as such. The other standard protocol of the treatment, management of gastroenteritis is mainly rehydration therapy, then antisecretory agents which can reduce the fecal material totally, like loperamide and so on, or antiemetics if necessary, symptomatic treatment. Zinc supplementation also is the other usual given as an antioxidant and anti-inflammatory. Probiotics also are known. Probiotics is simply something which facilitates the growth of the bacterial organism. Antimicrobial therapy is limited to a few of the conditions. I will come to that in detail. Then symptomatic therapy for abdominal pain or the fever and so on, the other part of the management. The in all that, sorry, in all that, the better management will be Mrityunjaya Ananda Bhairavi Mustakarishta, which will be quite effective uh, in large number of patients. Now, something about the antibiotic therapy and their standard protocol. The antibiotic therapy is not required in a large number of types like Bacillus, Campylobacter, C. difficile, and perfringens. This is the standard guideline given by the global CDC. Whereas the protocols of antibiotics may be required usually in Aromonas species and or the Plasmodium species. Vibrio cholera, of course, it requires the antibiotic. Tetracycline is a usual antibiotic. Yersinia species also may require the antibiotic. Other species do not require antibiotics. Rather, majority of the patients of bacterial colitis do not require antibiotics as such. But interestingly, that's the protocol which is given by the guideline of the WHO and the American CDC. The Western thought of the management of colitis is shifting towards a situation where the antibiotics are limited only to few of the conditions. But interestingly, in 2019, Indian Council of Medical Research has given an antibiotic policy which is applicable to the whole country, and that ICMR guidelines the antibiotic policy in the gastrointestinal tract pathology, diarrhea, as a primitive or as an empirical treatment. They suggested, there is a list of these suggested, like cholera, doxycycline, Shigella, ciprofloxacin, amoebiasis, metronidazole, of course, giardiasis, metronidazole, and Aromonas, ciprofloxacin is suggested as the standard antibiotic therapy. Administration of antibiotic for a long period, and either due to the colonic pathologies, the other may result in a situation which is called as antibiotic induced dysbiosis. Antibiotic induced dysbiosis is one of the troubles or one of the problems which are increasing in number, and this can result in a diarrhea, bloating, bad breath, halitosis, or fatigue and constipation, cause nausea, chest pain, vaginal or rectal itching, which also may produce a cognitive weakening, like the patients may not be able to concentrate, depression, anxiety, and so on. These kinds of the symptoms are becoming more common now in the patients who are given antibiotics irrationally for any of the conditions. This is not only limited to the gastrointestinal tract diseases, it could be any of the conditions. The antibiotics given can affect the microbiome of the intestines, and this can result in the renal fibrosis, atherosclerosis, cognitive malfunctions, cardiovascular diseases, and can predispose to viral infections and resistant infective conditions as such, and hence the antibiotic usage should be judicious. And the prebiotics and probiotics, these are the craze of the day. Now people are talking about the prebiotics and probiotics. Prebiotics are simply the food for probiotics, probiotics are those which contain some organisms, natural organisms like yogurt, milk, sour cream, so on. Whereas the food which is promoting these probiotics are the prebiotics like asparagus, wheat, and so on, and they are the major part of the management of the patients than really the antibiotics. That's about the colitis in general, bacterial colitis in general. Next, we will discuss in brief about the viral colitis and ulcerative colitis in the coming session, and wind up today. If there are any questions, we will try to answer right there. Right, there are no questions, so we'll wind up. Thank you.
Thank you, sir.